My name is Dr. Larissa May, and I'm an associate professor and the director of emergency department antibiotic stewardship at the University of California, Davis Medical Center in Sacramento. So we have one of the only antibiotic stewardship programs that exists in the emergency department in the country. And as part of that, we are conducting several studies related to rapid diagnostic testing in the emergency department. And we're very interested in moving those types of tests into the point of care and looking at clinical outcomes for our patients. The value of rapid diagnostics at the point of care is that you can really tailor your treatment in real time. So for those of us that work in an emergency department setting, we really don't have as much diagnostic information as some other settings because we're seeing patients in such a rapid way. We have multiple providers that are working in shift-based formats, and we often don't have access to culture information and other microbiological information. And what we really want to do is to be able to make the best decision immediately when we see the patient because we don't have the luxury of following them up. So really, point-of-care testing is the new paradigm shift, and I really think that in order for these rapid diagnostic tests to add value, they really need to be at the point of care. So really having a timely test available to the clinicians is really important. And when we've surveyed emergency department clinicians, they've really suggested that less than 30 minutes would be ideal. So molecular diagnostic testing affords several advantages that other types of tests don't. And I think really when we're talking in the emergency department about being able to diagnose a patient for whom we may not be able to follow up or have culture results, it's really important that those test results be accurate. And I think that that's one of the advantages that molecular does, is that we have more confidence that the result we're getting is real, that we have higher sensitivity, and that we can really make our clinical decisions based on that test result. In our study looking at the expert CTNG test, we basically randomized patients in a small pilot study to getting the rapid CTNG test with real-time result reporting in ED versus our standard of care, which was a nucleic acid amplification test that was done in a batched fashion and didn't come back for a couple days. And we really found a significant reduced chance that patients would get treated with unnecessary empiric antibiotic therapy. And it also really had a good impact on provider satisfaction because in that particular case, we were actually able to get the specimen at the point of care when the patient first checked in, either a urine or a vaginal self-collected swab. And by the time the clinician saw the patient, they already had the result. The patients were satisfied because they wanted the answers as to whether they had chlamydia and gonorrhea. The providers could make the decision right then and there to treat. And also, it often obviated the need for a pelvic exam, which was also really helpful for throughput and for workflow. So I think we really need to think carefully about which tests would best fit in the ED workflow. So I think that rapid molecular diagnostic tests have a really important role, and there's a tremendous opportunity to help target antibiotic selection, which would really be a paradigm shift. Instead of having empiric treatment for infections, we could actually know whether there's an infection and then pick the right drug, so the right antibiotic at the right time. That's an example, I think, in the ED where we could really make a difference.